now for Dr. Bashi Kumar Azad from the Human Rights in Childbirth. And she will start the opening session, Call for Global Actions to Improve the Quality of Maternal and Newborn Care. Dr. Bashi, it's an honor to have you here today. Thank you so much. The floor is yours.
Thank you so much, and good afternoon, everyone. And thank you to my wonderful hosts, the editors who brought you this widely read and highly successful IMAgiNE Euro issue that was published in the International Journal of Gynecology and Obstetrics. So I guess our gathering here this afternoon is very timely. It is in anticipation of the International Day of Women's Health on Sunday. I think it's Sunday, the 28th of May. And what better time is it to reflect on our obligation to raise the quality of maternity care, particularly around the time of childbirth. So the papers we saw published in the IMAgiNE Euro issue exposed, certainly from our perspective, some deeply concerning human rights violations. And let me say this at the outset, childbirth is a human rights issue. It's not just about the right to a private life, although that should be respected. There are a number of human rights that we consider to be inviolable as far as they concern every single human being on our planet. And they're especially relevant to the provision of healthcare, and specifically in this case, to maternity healthcare. And I'm referring to the right to bodily autonomy and integrity, the right to dignity, the right to privacy, the right to the highest attainable level of health, the right to be free from inhumane, cruel, or degrading treatment. And these are just to name a few. And all of these rights, when it comes to the provision of healthcare, they underpin an absolute and inviolable right to informed consent. Informed consent is a measure of dignity. It safeguards us against cruel and inhumane treatment and assault. And most importantly, it gives us a sense of agency. And agency is everything to human beings. And I would say in particular that it is everything for women in these modern times in particular. Agency underpins our freedoms, our liberties, our rights. And then time and again, we see, like we saw in the IMAgiNE Euro papers, there is an assumption that agency in terms of pregnant and birthing people can be ignored or set aside. And let me be very clear on this, they cannot. As I keep saying, or have said before, human rights apply to everyone at every stage, regardless of who they are, where they live, and for our purposes today, whether or not they are pregnant. And so some of you would know what I'm talking about when the UN Special Rapporteur, Dubravka Simonovic, told us in her report on obstetric violence that there were two major issues when it came to women's human rights in the provision of maternity care. First, that a woman's right to bodily autonomy and agency is compromised the minute she comes in contact with a maternity health facility. And secondly, she also said that informed consent is poorly understood and perhaps more concerningly, rarely respected when it comes to maternity health care in facilities. So one of the things that the IMAgiNE Euro papers highlights is that quality of maternity care from the perspective of women requires a lot more than just the production of a live mother and a live baby. Care that is delivered in violation of fundamental human rights is not care. In fact, from a human rights perspective, it is inhumane and degrading treatment. We know that mothers are important to us in our societies, but it's not just because they're mothers. We hear that a lot, or mothers to be. We are not just vessels. I think we need to remember when we're looking through all of these papers that we are talking about human beings. We are vital to the well-being of our communities, our economies, our children, and we also have the right to participate fully in our society, free from the unwanted consequences of assault and violence. And our organization, we hear from hundreds of women every year reporting injuries from facility-based care, their physical, their mental injuries. and some of them last a lifetime. And we do know this. We all know this. It should not be acceptable that women are reporting a standard of care that leaves them broken, unable to parent, and unable to contribute to society in a meaningful way. So one thing I must say as a closing, though, from my organization's perspective, Human Rights in Childbirth, we were very excited about the IMAgiNE Euro papers because I guess our perspective is that the papers had research that was calibrated around the voices of women or mothers' voices. 10 papers honoring the perspectives of mothers in 20 countries on the quality of care around childbirth. And from our perspective, that is how quality assessments and improvements should take place, with women at the center of the inquiry. So it's also our view, for example, that the only way to improve the quality of maternity health care, and this is whether it's in Europe, UK, Canada, USA, Asia Pacific, Europe, Africa, it is to shape services around the voices and needs of pregnant women and birthing people. Look, there are no shortage of women, I can say that for myself, who would like to be involved in improving quality of maternity care. There are many of us who are very passionate about this issue because there are many of us who have actually suffered from this sort of care. And contrary to the beliefs of health system managers and providers, who I hope will have an opportunity to review these papers and hear what we're talking about today, women are more than capable of telling you what care should look like that doesn't violate our fundamental human rights. So to cap it off, I think what I'd say is, if we are to imagine anything, as we hear from our speakers today, let's imagine what our maternity health systems would look like if they were developed through the perspectives of women, as opposed to the convenience of governments and healthcare providers. In the words of some of the Indigenous communities that I work with, I will say this: nothing for us without us. And I hope that's a good note to end on. Thank you very, very much for having me.
Thank you so much, Dr. Vashti. So I will now pass to Emma Sachs. Emma Sachs was not able to be in the webinar, but she left us a message that we are going to hear now.
Hello. Good morning, good afternoon, good evening to everyone, and thanks for joining. My name is Emma Sachs from the Johns Hopkins School of Public Health and the Technical Advisory Group of the IMAgiNE Euro study. The IMAgiNE Euro project developed, tested, and deployed an online survey for women who gave birth during the COVID pandemic. It included questions on sociodemographics, questions on standards of care, experiences of care, and changes related to the COVID pandemic. In this webinar, you will hear key results from multiple multi-country analyses from this study, covering issues such as the medicalization of childbirth, the experiences of migrants during this time, and general responses to COVID related to maternal, newborn, and child health. Before we start, I wanted to highlight two key themes that I think emerged across all of the papers that you'll hear about. One is the finding of a wide heterogeneity in the quality of care that exists between countries, with those in higher resource settings generally reporting higher quality of care, but also noting important quality gaps that exist around especially informed consent and autonomy. And the second one is, of course, that inequity exists within countries, with marginalized groups, including those who do not speak the dominant language, generally reporting worse experiences of care. I think you'll find all of these studies and findings very interesting, and I'm hopeful that they'll catalyze action as we continue to move forward and recover from the COVID pandemic. Of course, we aren't through the pandemic completely, and globally, as a health community, we continue to struggle with challenges related to climate change, migration, lack of universal health coverage, and attacks on reproductive autonomy. So I invite you to enjoy the presentations and think about the future actions that we can take together to protect women and newborns and their families. Thank you very much.
So after this talk from Emma, we will start the first presentation that will be held by Marzia Lazzarini, as she is the PI of the IMAgiNE Rural project. Marzia, I hand over to you.
Thank you. Thank you so much, Raquel, Bashi, and Emma for the inspiring introduction. And I'm delighted to be here in this webinar with all this group of people. So I'm Dr. Lazzarini. I am a pediatrician by background. I'm directing a WHO collaborating center based in Trieste in Italy. And I've also recently joined the London School of Hygiene and Tropical Medicine as part-time professor there. So if I can please have the next slide, I will guide you through some key findings of our IMAgiNE Europe project, starting from where we actually started. So we started 7 years ago with a pilot project based in our hospital. We are a third level referral maternal and child research center. We thought it was important to look at our practice and also to learn about the methodology of this study before scaling up. And then a few years later, we scale up to a regional level. And then with the start of the COVID pandemic, we then decided it was really important and relevant to document the quality of care. And so we decided to focus on the entire WHO European region. And the project was going on very well, having a sequence of new partners. And currently we have more than 70,000 mothers and newborns in the dataset and more than 7,000 health workers. Next slide, please. So the project is based on the WHO standards, which as WHO Collaborating Center, we contribute in developing. The standards are defining 318 quality measures, and they are organized in 3 major domains. So beside the usual domain of provision of care and resources, there is also a very important domain, the experience of care. And this domain is covering all these aspects such as dignity, privacy, and autonomy, to which Bashi was actually referring to. Next slide, please. So the objective of the project is to document the quality of maternal and newborn health care in the WHO European region. Currently, we are a network of 23 countries, 36 partner institutions. But as I was saying, we are growing up month by month, and the door is really open to new partners. People are welcome, so don't hesitate to get in touch if you feel that this topic is appealing to you. We are working through 2 online validated questionnaires. This has been translated in many different languages, precisely 28 languages for the mother survey and 17 for the health worker surveys. Overall, these 2 questionnaires include 80 quality measures, which has been prioritized from the WHO standard through structured Delphi process. And I have to say, we have been very productive in terms of documenting. So far, we have been publishing 20 papers, and 16 more papers are currently ongoing. And the idea is to go on with the network and continue documenting the quality of care in different phases. Now we can say we are in the post-pandemic phase, and so we can compare our data over time and not only across countries. Next slide, please. So how are data collected? So as I was saying, we have 2 questionnaires. They are fully online, so mother just click on their mobile phone and assess the questionnaire. They can choose which language they prefer to fill the questionnaires. This survey is promoted by all the partners, mostly through social media, but also through other channels. We have developed a lot of marketing material, which is already available in several languages. And once the mothers answer the survey, all the data are hosted in RedCap, and then they go analyze at regular intervals. And also they serve not only publication, but also quality improvement initiatives. Next slide, please. So this is just to say that we really wanted to validate our data collection tool. So we tested different domains of validity, starting from content validity to construct validity, phase validity, reliability over time, which is also called intra-rater agreement, internal consistency, acceptability, and utility. It was a long process, but I think it was worthwhile. And if you wish more details, you can also access the relevant publication. Next slide, please. The same was done also for the health worker questionnaire, although today we are specifically focusing on the maternal perspective. Next slide. So today we are presenting a selection of results from 5 papers. So I will start with our overarching paper, which is actually the first that we collectively produced and which focus on 12 countries. And then my colleagues will follow, bringing data on medicalization of care, migrant mothers, data on quality of care in private facility compared to public facility, and also a national perspective specific to Italy, which we selected because we think we need to show an attitude of self-criticism. So we want to start also by analyzing the data of our country where the WHO Collaborating Center is based. Next slide. So let's see which were the first result of the multi-country study. And this is also my opportunity to say that we are now in a position of having more data, also from the post-pandemic period. And so the next publication will allow us to compare the data that we collected during the pandemic to the most recent one. And I think this is going to be very interesting and relevant for us. Next slide. So what you see here is the first domain of the WHO framework, is the provision of care. For each domain, we selected 10 key indicators. They are reported as negative indicator to call the attention on the gap of quality. And what you see here is the frequency of each indicator. And the different dots are the different countries. So, for example, Croatia is in blue, French is in light blue, and so on. And what this picture is clearly showing is the extreme heterogeneity across countries, thus mirroring large inequities in quality of maternal and newborn care across all countries. So, for example, if we focus on indicator number 5, you see how the lack of breastfeeding was going from less than 5% in Luxembourg to almost 75% in Serbia, with many countries in the middle. Next slide, please. This is the second domain of the WHO framework, is the experience of care. So it's all, these are all items related to dignity, privacy, emotional support, experience of abuse. And again, you see how data are divergent across different countries. But also you see how there is no country free from gaps. And for example, the key indicator that Bashi was also remembering us about the lack of consent. So you see how the country with a lower frequency, which is in purple, and is actually Sweden, still mothers are reporting a lack of informed consent in about 40% of cases. Next slide, please. This is the availability of human and physical resources. And again, we see how data are heterogeneous. We see how there is major heterogeneity in the partner visiting hours. Let us remember that these are data from the COVID period. And also, I like to use this slide to show how there is a pattern among countries which is quite systematic. So you see here very well how the pink dot is on one extreme of the graph, and the green dot is on the other extreme. So Luxembourg is the green dot, which always show the best quality, while the pink one is Serbia, which is always on the other side. So when inequities are systematic and preventable, they can be called, when inequalities are systematic and preventable, they should be called inequity. And it's an issue of human rights. Next slide, please. This is the last domain on organizational changes due to COVID. And here, as a key message, we really would like to emphasize that several aspects of care were inadequate, but I want to call attention specifically on the insufficient number of staff, of healthcare professionals, which is indicator number 8, which is a problem which has been reported by many reports in the European region recently, and is generally aligned with the impoverishment of our health system. And we are lacking more and more resources. And this is something that we should tackle at policy level. Next slide, please. We also calculated an index as a complementary, not substitutive way of measuring quality of care. This was calculating according to predefined criteria through a score system. So what you see in these images are the distribution of the quality index in the different countries. And so again, this picture confirms the previous data. And you see how the blue curve, which is Romania and Serbia, they're quite different from the green one, which is showing the highest score, and which is on the right side of the graph. So Croatia, Romania, and Serbia, when corrected for population characteristics, had significant lower quality of care index. Also, younger women, operative births, and premiferous had lower index of quality of care, and also women giving birth in 2020 compared to 2021. And we now hope to compare this data over time so that our study can also serve as a monitoring tool on the quality of care in the European region. Next slide, please. And this was my last slide, and I'm happy to hand over to Celine. Thank you very much.
Thank you very much, Marcia. I am Celine Miliani, researching reproductive health at Bielefeld University in Germany. I will present you today the key results on medicalization of birth in 15 countries. So we are still here with the reduced sample since it was one of the first analyses we conducted as well. Next slide, please. So here you have the link to the article that was published in the supplement. And so what do we mean by medicalization? I'm referring here to the WHO definition, which is the application of a range of labor practices to initiate, accelerate, terminate, regulate, or monitor the physiological process of birth, which also tends to undermine the woman's own capability to give birth and negatively impacts her childbirth experience. And so building on that, the WHO made recommendations saying that high cesarean rates, routine or liberal use of episiotomy, and any kind of fetal pressure should be avoided. Despite that, we see that the rate of interventions varies across Europe with, for example, from 16% of cesarean section in the Netherlands to 39% in Poland. So we tried to look at that and understand what was happening thanks to our data on several countries. Next slide, please. Traditionally, the research on the medicalization of birth focused on the individual determinants, but the broader context of a country, such as the healthcare system, the care culture, the social norms, may also be at play. And here we had the opportunity to look at a range of countries and to investigate that. For example, investing in model of care that give more space and responsibility to midwives can potentially help reduce the number of unnecessary interventions, but also social norms, gender norms can influence how reproductive health is perceived and reproductive healthcare organized. So please, next slide. We wanted to investigate the influence of those factors at the individual level that are more traditional and the factors at the country level. So we built some what is called some multi-level analysis with modeling at the different levels. As our outcome, we took some indicators of medicalization, namely having a cesarean section, an instrumental vaginal birth, having received fundal pressure during an instrumental vaginal birth, and having received an episiotomy. At the individual level, we look at the type of facility, we look at the measures of respectful maternity care, we look at the presence of a midwife or a midwife and physician. And at the country level, we try to find some indicators of the care culture, for example, or of any kind of social norms that could be helpful in understanding the differences in practices. So we looked at the number of midwives per 100,000 inhabitants, the cesarean rate at the national level, a gender equality index that allowed to compare countries in terms of gender and social norms, and economic indicators such as the GDP. We, of course, controlled for age parity, education, and migration. Next. So this is the 15 countries that we included in this analysis. Next, please. And what we found that actually most of the factors associated with the medicalization of care were located at the individual level. And the women who perceived care as more respectful tend to receive fewer interventions. Although through this cross-sectional design, we cannot say in which direction this relationship goes. It could be that a more women-centered approach to care limits interventions, that more involvement in choices, for example, lead to fewer episiotomies. But it could also mean that women in general perceive less interventionist care as more respectful. This should be investigated further. And we saw a weak association with the macro factor at the country level, but yet the multi-level model had a better fit, a statistical fit, suggesting that the national context still matters. And maybe the indicators we chose at the national level which were only proxies of care culture, were not the most appropriate, but there were no better ones we found. And that one recommendation for the future would be to have more specific indicators which more explicitly relate to reproductive health at the national level to inform our knowledge and understanding of the differences in practices. I thank you for your attention. And I will pass now the relay to Ilaria Mariani from the WHO Collaborating Center in Trieste.
Thank you, Céline, for the interesting overview on medicalization of birth. And thank you, Bashi and Marcia, for the introduction. I am Ilaria Mariani, researcher, midwife, and biostatistician at the WHO Collaborating Center in Trieste. I'm really honored to be part of this webinar, and now we'll present you the results on a mode of birth in private versus public facilities. Next slide, please. This is a multi-country analysis, yes, including data from 16 countries, and this sample of this study included more than 25,000 women. When corrected for the population characteristics, results from the multivariate analysis showed that instrumental birth and cesarean section had a higher odds ratio in private facilities compared to public facilities. This result is in line with evidence from other studies reporting different rates of cesarean between private and public facilities. And also other studies from the IMAgiNE project reported similar results, with the quality of care differences between private and public facilities. We also conducted an analysis by country. Next slide, please. And for each country, we studied how the quality of care index differed by domain of care and type of facility. And looking at Portuguese and Romanian data, the figures show you that the quality of care index, both on public facilities, the light curves, and the private facilities, the dark curves. If you focus your attention on provision of care domain, the blue curves, you can clearly see that the shape of the curve mostly differ by country. And in all domains of care, Portuguese curves are more skewed than the Romanian ones. This underlines that the quality of care was largely affected by the geographical distribution rather than by type of facility alone. We also found a significant difference within country. Next slide, please. And the IMAgiNE group conducted several studies focused on national data. Now I will briefly present you the Italian data as an example, mirroring our attitude to self-reflection. Next slide, please. And results from this study highlighted that there are inequities in the quality of care in all Italian regions, represented by the colored dots, and that there is heterogeneity within Italy, with a wide range of gaps in the quality of care in most of the indicators we assessed. This means that the quality of care should be closely monitored in all facilities to achieve high quality of care independent of the facility type or the geographical distribution. Next slide, please. And this was my last slide. Now I turn the floor over to my colleague Raquel, and thank you for the attention.
Hello, thank you so much, Ilaria. My name is Raquel Costa. I'm a researcher at the Institute of Public Health of University of Porto in Portugal. And I'm going to talk to you about the key results on migrant maternal and newborn care in 11 countries. Next slide, please. So this is the QR code for the paper that we published in the supplement. And over the last 2 decades, the number of international migrants has increased by more than 100 million worldwide. And about 90 million international migrants live in the WHO European region, accounting for almost 10% of the population in the region and 35% of the global international migrant population. So the International Organization for Migrants has alerted that a crisis in migration is expected in the WHO European region. Therefore, the WHO has highlighted the urgency of integrating health data from migrant populations to assist in the development of adequate response plans and healthcare preparedness. However, even in the European region, there is an overall lack of routine standardized monitoring systems for assessing and comparing the quality of care overall and by migrant status. Next slide, please. So the aim of this study was to describe the maternal perception of the quality of care around the time of childbirth among migrant versus non-migrant women during the COVID-19 pandemic in 11 countries of the WHO European region. Next slide, please. In this analysis, we included 22,434 women, 92% were non-migrants, and 8% were migrants. And they all filled the questionnaire based on the WHO standards that have the 40 indicators in 4 domains, and we have computed the total quality index. So what we saw in this analysis was that migrant women who experienced labor were more likely to face barriers in accessing the facility, difficulties in attending routine antenatal visits, inadequate number of women per room, inadequate room comfort and equipment, no timely care at facility arrival. They were more likely to report physical, verbal, or emotional abuse, not allowed to stay with the baby as wished, and on the other hand, they were less likely to not early breastfeed. Among women who had a pre-labor cesarean, migrant ones were more likely not to receive pain relief after cesarean and were less likely to provide informal payment compared to non-migrant women who had a pre-labor cesarean. Next slide. So when we look at this slide, and when we look at this at the blue graphic, what we see is the dimension of the provision of care. And what this slide and what this graphic shows is that in Slovenia and in Sweden, migrant women reported lower medium quality of care, of provision of care, compared to non-migrant women. If you look at the yellow graphic, what we see here is that in Croatia and in Portugal, migrant women reported lower mediums in the availability of human and physical resources compared to non-migrant women. But what we also found was an inverse association in Luxembourg. So what we found in Luxembourg was that migrant women had higher medium scores in the availability of human and physical resources, as well as in the organizational changes due to COVID-19 that you can see in the gray graphic in this slide. So we haven't found any differences regarding the experience of care between migrant and non-migrant women when we look at this panorama from each of the countries. Next slide, please. Overall, what we found was that in Portugal, migrant women reported lower medium quality of care compared to non-migrant women, whereas in the Luxembourg, we found the other way around patterns. So migrant women reporting higher medium scores on the quality of care. Nonetheless, when we look at this analysis and we adjusted the analysis for the sociodemographic and perinatal characteristics, we found no association. So we found differences in the healthcare between migrant and non-migrant women that are highly dependent on the hosting country. Qualitative studies with mothers and healthcare providers could inform factors that determine uptake and quality of care for migrant women in specific countries. And overall, we found gaps in the quality of care that were reported by both migrant and non-migrant women, showing that improvements for healthcare are necessary for all. Next slide. Thank you so much for your attention. I will pass it over to Emmanuel Pesavalente now. Thank you.
Thank you very much, Raquel. It's a pleasure to be here. Welcome you all. I'm Emanuele Pesavalente. I'm a gynecologist by background, and I'm senior researcher at the WHO for maternal and child health from Trieste, Italy. We are going to talk more about how to become an IMAgiNE Euro partner. Next, please. Who we are. We are a network of very motivated volunteers. We are doctors, midwives, public health specialists, and women rights advocates from 23 countries. Here we can see just some of us. We now are more than 70 researchers from those institutions where that we can see the logos here. Next, please. And what is the role of the coordinating center, the WHO collaborating center from Trieste? We provide the logo and visual identity of the project. Our website is coming soon, and we provide partners with marketing material to promote both surveys for mothers and surveys for health workers. We organize monthly meetings online, and we share detailed minutes of actions discussed, the next steps for partners who are not able to come. All data analysis is centralized in Italy, and we support partners on publications. We provide data also for Congress presentations, posters, and oral presentations worldwide. And we support partners on press release and media at international and national level. We are now dedicating some energy to the translation of those evidence into policies. So we support partners also in these quality improvement initiatives. Next, please. And what are the key role of partners? They have few tasks in the beginning when joining the project. They need to translate the surveys if the questionnaires are not available in their national languages. Please note that we have now online 28 languages for mothers and 17 languages for health workers. But the whole process is supported by the WHO Collaborating Center. We provide templates. We support the translation in all steps with standard operating procedures. And usually it takes around 3 weeks, 4 weeks maximum. And the questionnaires will be online in the new language. Partners are also responsible to explore the need of an ethical clearance, because in most countries the ethical clearance was waived because we already have several ethical clearance from other countries. We provide marketing materials in several languages. We can translate marketing materials in whatever language you would like to have, especially to focus on the migrant population in your country. If you need it, we can translate marketing materials. And as Marcia explained before, surveys are promoted in social media. Data is hosted in REDCap, and we support partners in publications and quality improvement initiatives. Next, please. I listed here the most frequently questions that I received from future partners. How authorship is decided for multi-country publications, for example. We have a clear authorship criteria based on sample contribution for each specific paper. Also, the IMAgiNE study group is acknowledged in all publications, and all researchers that are part of the group are listed there. We strongly support national publications because we believe that it's an important initiative to translate evidence into policies and into practices. Partners have no financial obligations with the WHO Collaborating Center or with the project. And we promote all partners' logo on our webpage, in our surveys, or in events like this webinar today. If your country is already an IMAgiNE partner, it's not a problem. More than one institution can join from each country. We'll be happy to receive new partners from all countries of the 53 countries of the WHO European region. Next, please. Next. Well, that was my last slide. Was just to thank all researchers from the IMAgiNE study group and the coordinating team. If colleagues can, yes, if you would like to become an official IMAgiNE partner, we will send to all registered participants the application form. It's a very short form where you can express your intentions of being on how to contribute to our project. And I will be happy to organize a call where I will give you further details on this study. Thank you very much. Next, please. Here is the list of our partner institutions that I would like to give my warmest thank yous to all researchers involved and our coordination team from the WHO Collaborating Center in Trieste. Thank you. Next. Thank you very much for your participation. I will now give the floor to the section next, please. To the questions and answers and the discussion sections. We will have 10 to 15 minutes to this very open moment of our webinar. So please, if you would like to make questions, please raise your hand or use the chat. We will be happy to answer about it. In the chat, I can see that we have the requests for the reference of all papers. My colleague had answered, and I can say that all papers were published in an open access way, so are free. You can download them freely from the PubMed, or if you start even using Google, you can find the PDF available of all papers. Do we have questions? Please. It's a very informal moment. If you wouldn't like to talk, it's not a problem. You can write in the chat. And thank you very much for the congratulations and the appreciation messages that we see here in the chat. Thank you. Thank you all. We have also a Gmail of the project that my colleague Raquel wrote in the chat. So if you reflecting after this webinar, if you would like to make questions by email, please feel free to write to us. I will be happy to answer you in a couple of days.
Emmanuel, there was a question, where can I find the form? And as I think you said, it will be sent to all the persons who registered for this webinar, right?
Yes, yes. Thank you, Celine. The link will be shared to the email that you used to register in this webinar. But if you would like to use a different email or to add other email addresses, please write just now in the chat that we will add this new email to our mailing list. Thank you.
And where can we find the recording?
The recording will be available after. I think that Raquel can confirm better this information, but I believe is in the webpage of the Portuguese partner.
Yes,
Raquel,
yes. So
please.
we will send the link to all of the participants. So there will be a link to watch the video, and we will send it to everyone that was participating today with us. And you can share, of course, because this is open, okay?
Thank you, Raquel. Thank you. We have questions in the chat. Thank you. Ilana Chertok asked, now that COVID-19 is more contained and mitigated, what is the next focus of research among this group? I would kindly ask Marcia to answer this question. Thank you.
Thank you very much, Emmanuel, and thank you, Ilana, for this question. And also, thanks again to all the group. I'm saying that because actually we are discussing internally what is the focus. And the group is heterogeneous, there are different interests. So there is an interest on breastfeeding, there is an interest on adding perhaps some new variables to our questionnaire. In general, I think there is an interest in going on with our assessment, and so documenting really whether quality of care has actually improved now that we are in the post-pandemic period, or whether it is still a sort of stable. You know that there are many evidence from the pre-pandemic period of gaps existing even before. I just want to mention a couple of initiatives, such as the Babies Born Better, which is a national survey, very large. So we hope that our data at the end will have an impact really on policies. And here I'm getting to the other point. So what we really would like to invest more is in translation of this evidence into policies. So far, we have done several activities under the site, including a webinar, including promotional material, several media and press release, which were done in many countries. It's about 10 pages of links of press release. And also we approached the European Parliament and we share the findings among the main list of MP members. But we also welcome any advice that you may have in that direction on how better influence policies. Yeah, and that's all from my side, but I invite Manuel or Ilaria to add something if they have something to add. Thank you.
Thank you, Marcia. Thank you. We have other questions in the chat, and there is not the name of the participant, but she or he asked, would it be okay if we join this year to start using the revised questionnaire, the one not focused so much on COVID-related questions? And I can say, yes, we are. This is a very goal of our network this year. We are revising the questionnaires, but we will the variables, important variables, key variables for respectful maternity care for the WHO standards domains will remain in the questionnaire. So we have the objective to compare data over time. So it will be okay if you join this year, because your data will still be comparable, even if we modify, we revise the questionnaire. And that's it. Now the rounds of data collections are active, are ongoing in several countries, while other countries had stopped, the first countries, for logistic situations in the national settings. Other countries are still collecting data. So all links are open. And I will give the floor to Raquel, maybe to answer the next question from Nakashiu Swinet that asks...
the next question is
in the chat. How do you see the quality of maternity care service in the humanitarian setting? I think it's a very interesting question. I give the floor to Raquel, because the paper on migrant was presented by her.
Yes,
Raquel.
Actually, I think that, Dr. Bashi in the beginning has made us hear a very well, overview of what is the birth or the childbirth in terms of the human rights. And also here on the migrant issues, what we saw is that we are having, in the Europe, there's a huge change in terms of migration. And we really need to take care of people that are flowing through the countries in Europe and take into consideration their culture, their, costumes, values, to provide the best care, attending to their needs, their specific needs. So respectful care centered in the woman implies that we are So in my perspective, for instance, in Portugal, we are collecting also data in the setting. And what we find here is that more and more we are seeing people that don't even speak Portuguese, and our settings need to be transformed and adapted so that the healthcare providers can really have a conscience of the situation in the circumstances of people that were not born in Portugal so that they can attend to their needs, their specific needs. I think we really need to invest in this.
Thank you very much, Raquel. We think that we have one more question, and we have to close this section. About the migrants, do you perceive differences between migrant groups, for instance, by country of birth or literacy? Raíza Guedes.
Yes, so
Raquel,
that's a very good question. We do not have information on the country of birth. So we know that the person was not born in that country, but we don't know where does the person come from. There are some studies that show that there are differences depending on the place that the person is coming from, and also, and that's a relevant issue. And also we are aware that in our sample, the migrant women that participated in our study, they have a high education level, so we might expect worse experiences among those women that do not have these educational levels and that are in a more disadvantaged situation. So we believe that what we are reporting is the best case scenario. So it should be, we should also target women in more disadvantaged situations so that we can, have a global overview on all of these circumstances.
Thank you, Raquel. Thank you. I need to say just that when we launched the survey, we selected very few sensitive questions from the personal background of the woman in order to speed the ethical clearance in so many countries, because we had the urgency to collect women views. So maybe in this updating of the questionnaire, we will reflect on which questions regarding to the social demographic backgrounds of the woman would be interesting to add in the survey. Thank you very much for all questions. We are delighted to have here today the president of the FIGO, Dr. Jane Conry, and also the president of the International Midwife Confederation, Dr. Franca Cade. I will give the floor now to Dr. Jane Conry, and please to start the closing section of this webinar. Thank you.
Thank you. Thank you to all who are involved in this IMAgiNE Neuro study for a very heartfelt discussion today, but what a well-organized presentation of a huge and what I can call an all-encompassing database. Presenting data and then sharing it very broadly is really the only way I expect changes in care delivery, and I commend every one of you for doing this. You've identified the variations based on geography, healthcare facility, migrant status, access in the very broadest sense. Healthcare professionals, unfortunately, will often bring inherent bias, racism, inherent inequities, and inherent expectations on how individuals are treated. These studies unmask these inequities on a limited scale, but a pretty broad one if you look, it's across Europe, but it's very likely reflective around the globe. Whether we call this the culture of care, the studies reflect basic and concerning inequities. And I firmly believe that change will happen when we are all held accountable, and accountability relies on data presented here. I would argue that although policy changes, as you've talked about at the European Union level or whatever, might be key, it is actually presentations on the ground in the facilities with the healthcare providers, comparing and showing them these kind of data is really, to me, the key if you really want to bring about change. FIGO represents over 130 societies of obstetricians and gynecologists around the world, the women that we serve, and we're the global voice for women's health. We believe in patient-centered collaborative care that supports a holistic approach to women's health across the lifespan, really from adolescence through maturity. And we respond to women's needs and desires. We believe that safe and respectful care is at the very center of our sphere, whether it's safe and respectful care and how we deal with patients and families, colleagues, every step of the way. What you've looked at here And we recognize 2020 will be remembered as that time when our lives, our health systems, and the world changed and turned on end. So the research chronicles that time, but I think it reflects much more when we look at the treatment of women. The information shared takes us back to the very beginning of the pandemic when fear was all-encompassing. The decisions about maternal health, the decisions on how we treated women were based on fear. And what I think is important to recall is that we had the fear of losing a patient, the fear of bringing an infection home to our families, the fear that your child would die because you brought an infection home from the hospital. But what it shows is that we can do and must do better. When we speak of disaster preparedness, the needs of women and families have to be prioritized, and that can only happen with the awareness and the attention to the history, the conscious decisions that we make when we're coordinating healthcare systems, and the research that you presented here. So even though this may be COVID related, I believe it's basic to how we do disaster preparedness and also how we approach labor and delivery and look at what we need to do better. So I commend all of you. I would argue that one of the steps that has to take place is going back to each of the units, comparing and showing them where they stand, because I'm a firm believer in data comparison. So thank you, and my commendations to all of you.
Thank you. Thank you very much, Janie. I will give the floor now to Dr. Franca Cadet.
Thank you so much, Emmanuel. Thank you so much. And thank you to Jeannie. Thank you to the other speakers. Amazing research. Thank you to the research for doing this. It's really, really impressive. And also your growing numbers of members. I think that is really shows that this really, really matters. And ICM is an organization. We are the unifying organization of midwives globally, 142 organizations, around 1 million midwives. And we're actually striving to make sure that we don't see women as patients, but as women, as healthy people that we try to keep. We try to keep the normal, but of course prefer when not. And then we work in good collaboration with our obstetric colleagues. Now, a lot of what I've heard today is not strange to ICM. I think a lot of what we hear actually also happens to midwives, because the same kind of abuse often happens to midwives. But that doesn't mean that midwives don't do the abuse themselves. And I would really like to talk about that, because I think midwives themselves are not angels either. And though we might be compassionate and understand why they might abuse their power, it happens and it's never okay. And as ICM, I really think it's important that we look at this, that we understand this, and that we work with our midwives in the world globally to make sure that we give compassionate care. I think midwifery has within it the ability to be able to do that, but there's all kinds of reasons why it doesn't happen. And so I think it's really important that we look at that and that we work with that. It also looks as if sexual reproductive health and rights, just like Bashi said, as if it's not an issue during pandemics, or if it's not an issue in humanitarian settings. But it's never not an issue. It can't ever not be an issue. And I think this is something that we really have to face, that maybe even especially in these settings, when we're under stress, when we're slightly less likely to be able to think through decisions, that we really have to remember that the human rights are there to be observed, full stop, not so much of women or birthing people or whoever, of everyone. Human rights have to be respected always. And I think that one thing that I've seen in the research that's really happened is the idea of informed consent, that there was just no informed consent. I found, again, it's very familiar to me, but I've also found it shocking. And I think I can really see this as an indicator. It's an indicator of the type of care that we are giving and the way that we are supported to give our care. And we really need to be able to be supported to look at making sure that we have shared decision making, true shared decision making, and really understanding what informed consent means. The fact that the improvements that we've made through decades seem to have just disappeared in such a short period of time, I found shocking. I didn't realize that it could go so quickly. And it just shows how it's not really been integrated into our system yet. I think we have very good intentions. We've done really great, but somehow the COVID pandemic came and whoopa, just like that, all kinds of things disappeared. And especially with immigrants, Your research really shows that well. So those people who are most left behind are the ones that suffer most. And basically what you've said is what so many have said. We need to listen to mothers. We need to listen to birthing people. That's how simple it is. And I think as ICM, we need to be reminded of this as well. We need to make sure that we give the women a voice, and that's what you have done. Your research has actually given many, many women a voice, and we need to listen to this. So we are, as ICM, trying hard to work towards a paradigm shift, where we go from a medicalized model of care to a midwife-led model of care, where you have, because we know that this model of care gives more respect, fewer medical interventions, and it's the only way forward if we want to make sure that we give the type of care that women need and the type of care that we all support. And besides that, financially, I think it's also much better for us all. I think that also midwife-led care it's about women. Actually, in many ways, I think it's women-led care. And it truly understands what consent and what shared decision-making means. So I would like to ask you as researchers and as people, hold us to account. Because as I said, midwives are not angels either. We need to be held to account. We need to be reminded. I think sometimes as midwives, we just kind of get into our work and we forget the system we're in. And we really need to be reminded. And I think research like this is a really good example of how we can change the paradigm together. So I'm really thankful to all of you for doing this. Thank you.
Thank you very much. Thank you very much, Franca. Thank you very much, Janie, Bashi, Emma, Sachs, all speakers today and all participants. It was a pleasure to be here. We will share with you in a mailing list the link for the recorded webinar and also informations about upcoming webinars from our group. We think that it's a good strategy to reach people, to disseminate our results. So thank you for your